Thank you.
So good afternoon or good morning, depends on the hour. First of all, let me say thank you to Dr. Sideris and Skevos, to the scientific committee for organizing this conference and for invitation. I'm very happy, and this is my first time in Athens. So I prepared my talk about substrate mapping because I think it's very important in the context of VT ablation. These are my disclosures. So the ideal flow chart in the setting of VT ablation is first to build up an electrical substrate map. So you want to create the geometry and you want to understand where healthy tissue is from the scar. And then you want to study the abnormal propagation of the art. So you want to understand exactly where the slow conduction are. This is what we do at our institution. You see the red is all the potential inside the QRS, and when they are the slow conduction, you have some late activity. And this island of violet color is represented by late potential. So the key points in this figure is that we want to study the electrical propagation and to localize where the area of the VT circuit most likely are. And so we place usually our pentaray catheter, so the multi-spline multi-electrode tool, because we want to depict the full diastolic pathway, like in this case. You see on the left panel, you see the entrance and the isthmus, and on the right panel, you have the exit site of the VT circuit. And then you place your ablation catheter on this area, and you see in 10 seconds, you interrupt the VT circuit, and you have the sinus rhythm restoration. So then you want to link the abnormal activity you have recorded with the VT reentrant circuits, because you want to establish an endpoint. The endpoint is to have the complete electrical silence. You see the first map on the left is the one we started. So you see there is an area of late potential quite big. Then we ablated. There is a second picture because we did a remap. And you see there is still some area of late potential. So we ablated more, and you see at the last map, the last panel shows an almost complete abolition of late potential. So we should always reach this kind of abolition of late potential. And I will show you later the reason. And this is what you like at the end of the procedure, the non-inducibility. So the patient should not be anymore inducible. So this is the whole procedure of the VT ablation. So the first part is represented by the mapping and by the ablation. So you're treating the patient. And then you have a second part represented by the prevention. So you link the abnormal substrate to the VT circuit and you abolish every late potential expression of slow conduction, so you prevent the patient to come back to the lab. So the agenda of today will be why the substrate is so important. So yesterday, how was it? How is it today? And how will be tomorrow? So it's very important to define the substrate mapping because first, you have to distinguish where the scar is and where the healthy tissue is. And then you have to understand where the late potential and lava are. And then you have to orientate yourself in the chamber of interest. And then because you want to improve the long-term outcome of VT ablation. And the substrate is like a soccer game or rugby game. So you have to know, and you have to understand the rules. So you have to know which materials, which cutters, what you're looking at. So you have always to ask yourself which is the best cutter, which side I should map, endocardial, epicardial, and then what are the targets, so lava or late potential, and then should I do an activation or a substrate only map? And this is what we do. So these are the tiny signal we are looking at. So the first you see under the QRS are the lava, local abnormal ventricular activity, and then there are late potential. Oh, thank you. So this is the QRS. You see the surface ECG, And down here you see all these fractionated EGM, which are represented by lava. And then you have this such tiny signal here, well represented here, that are the lay potential. So we are looking for these signals. And the reason is because, as you see from this Kaplan-Meier curve, the patients that at the end of the procedure are non-inducible, and plus you abolish every lay potential, are going much better when compared to patients where VT is not inducible, but you did not chase every lay potential. And this is a paper from our group published in Circulation 2014. So the electrical substrate yesterday was characterized by these such spiky geometries you see were made by the ablation catheter. You see less than 50 points maybe, but these were the first representation of the ventricles. So the first time that we recorded the scar, the red, so where is red is scar, where is border zone, and then there is healthy tissue. So this was the first representation ever of VT, and this was made by Marcinski in Circulation 2000. And the amplitude was defined as 1.5 millivolt healthy and below 0.5 scar. And then you see here another paper published in 2003 by a Canadian group. They tried to define the target area when there was a lower capture threshold 10 milliampere and 2 milliseconds width. But the substrate modification currently are the following. So the first one is the homogenization by DiBiase. Is an anatomical based only on scale identification, so there is no electrophysiology here. It's just homogenization wherever you are. And indeed, I like this free approach. So our approach based on lay potential, the lava based by the Bordeaux group, and then Berruezzo that proposed the channeling. And these are electrical. These are just for electrophysiologists, I do believe. So you have to search for abnormal activity and eliminate them. So the electrical substrate today is characterized by this is the keyword, I do believe, is the multi-electrode. And when you do this search on PubMed, you see there is an increase of publication. And so today, the keywords are these: Pentarray, so for the Carter system, there is the Orion for the Boston Scientific, and then the HD grid by Abbott. And these are the new hashtags for people that love Twitter. So high density, the capability to distinguish near field versus far field, and then the activation wavefront as well, the software algorithms. So you see, these are the substrate mapping we are now able to create in our labs. So there is high density. And you see clearly this patient was a patient with ARVD, with dysplasia of the right ventricle. You see the scar is extending from the RVOT to the inferior aspect of the RV, very basal, and also to the inferior wall, when here is healthy tissue. And so if you can magnify, you see there is a high definition of the substrate, so you can tell exactly what's going on here, and you can distinguish the normal tissue from the scar. And also, you can tell the high definition of a scar is critically dependent upon the activation wavefront, the electrical size, and also the interelectrode distance, which are the properties of the catheters we are using at. So these are the signals we are characterizing. So you see we are looking at, we can really distinguish the near field potential. So these potential are those potentials that are happening just below your catheter. So it's sharp, it's very high frequency, compared to this signal, which is a far field signal, which is very rounded, is very low frequency. So with this multi-electron mapping tool, you can distinguish the two. And then this is the catheter by the Abbott system, is the HD grid. You can tell there are 16 electrodes you see here, and are able to map the signal along the spline, but also across the spine. So what you can get is these beautiful maps from one acquisition. You can have this one, so you see there is a really extended area of scar. Then you have another one, same patient along the spine, so just an acquisition made by this sense of the spine, and then with the algorithm present in this system. And when you compare the all three, you can tell the scar is really different. So it's very important to use the correct mapping catheter. And when you compare the new mapping technology with the previous one, where we were able to map only with the ablation catheter, you can tell the difference between the two. So the secret is the shorter distance, the best resolution, the best characterization. And then you can play with the algorithms that are now integrated in our mapping system. You see here, this is the bipolar map, an extended area of scar, and on the right, the propagation map during sinus rhythm, and this is the line of block, this white color here, this white line, which is added automatically by the system. But also you can play with other algorithms like the one by Boston Scientific. This is the LumiPoint, and you see during sinus rhythm, this is the highlighted area automatically done by the system, which corresponded exactly to the VT circuit. You see here, this is the entrance, the isthmus, and the exit site of it, the VT. So this is the Orion tool. It's a really great catheter. The electrode is very tiny. It's 1.4 millimeters squared and is 1.7 millimeter the inter-electrode distance. This is able to map such tiny, really tiny, long fractionated EGMs. So when to understand when to go epi and when to go endo. So these are some cases I did together with Professor Della Bella. So this is a patient, 48 years old, with myocardial infarction, ejection fraction 38%, and this patient had the VT despite amiodarone. You can tell here is a VT coming from the inferior wall. The QRS are negative in the D2, D3 AVF, and the AVL is positive, so it's coming from the right to the left, and the precordial leads suggests is coming from the medioventricular wall of the left ventricle. So we started with this map, so endocardially. You see this is our subset mapping, and it's quite healthy here, and at the basal portion of the posterior wall there is an area of scar. But when we went unipolar, so you have always, it's always very important to look at the unipolar map, because in this case you see is showing you there is a large extended area of scar compared to that one. So when also the late potential activity, you see the awareness is always white. There is something here, but not so present. So what we did is to try to induce the VT, and we did not map the VT. There was no circuit endocardially. So we did the puncture, and you see this is the epicardial scar, very, very big, huge, that the unipolar one was showing us from the endo. And also the late potential activity was really big. You see very red and also borders in the green and blue area. So we induce the VT, and as you see, we place this decapolar catheter, and here you have all the VT circuit, the entrance, the isthmus, and the exit site. So this is the full depiction of the VT circuit. And then we did a remap, you see. So this is the first map, this is the second map. You see there is a change, but there is still some area of late potential. So with you see also the signal, there is still some signal present. So we ablated more until we have this abolition of the signal. And you see clearly now the complete abolition of the signal. So here there is a lot of late potential, there is some late potential here, and then at the last remap, no late potential. So, and this is obviously the last ECG, you see 4 extra steam, no inducibility. So lay potential are the VT circuit and is always codifying for the VT circuit. This is another case, is a patient with myocarditis, is an epicardial scar. You see very huge, and also the unipolar was concordant with the bipolar. And when we were mapping, you see there is an area of lay potential, you see, coming very late after the QRS, and the core of the lay potential is in this area. And this is what we have found. You see the activation. So this is the entrance. A little bit down is the isthmus. Here you see the mid-diastolic potential, and a little bit down is indeed the exit. So this is what we do in our lab to depict the full diastolic cycle length. And this is the propagation. You see the entrance, the exit, outer loop, then there is a wavefront collision here, entrance, isthmus, and so on. So, and this is the remap. You see before and after. There is no more lay potential at the same area. So before and after. So this is the lay potential activity, and here at the same place, no complete abolition. There is a complete abolition of lay potential. But sometimes the lay potential are not the VT circuit. You see here is an epicardial map of an ARVD patient, and here is the extended area of a scar, and this is where we found the lay potential. You see the lay potential here, and when indeed we mapped the VT was a little bit below. So here is where we found the lay potential, and the VT circuit was a little down. So this is the isthmus. You see tiny mesodiastolic potential, and here indeed we are at the exit side. So there is a mismatch. You can tell exactly from where we recorded the two lay potential. I think this is very important, is the future of substrate mapping. And this is the research I'm performing at the Sir Raffaele Hospital. We are running simulation, mathematical simulation of the propagation of the heart. So I'm quite convinced it's very important to tell which is the fast substrate, the endocardial or the epicardial. So you see here, this is a screenshot. You can tell exactly the endocardial is getting slow, while the epicardium, which is this one here, is getting fast. And also we are trying to characterize VT circuit, not only the inner loop, but also the outer loop, because this is the most important part of the circuit, but also this is very important, so what is called the outer loop. And so we are exporting our map to MATLAB, which is our engineer software, and we are asking to characterize the velocity of conduction. So here you see this is the inner loop. At the entrance is going very slow, then the speed increase and then go slow again. And then you see this is the definition also of the outer loop. And this is the outer loop analyzed with the MATLAB. You see here is going very slow, it's getting higher again at speed, slow, higher, and so on. So it's another way to represent, and I think this is the future of substrate mapping, the activation wavefront during VT. So also we are exporting our map from Navex, from Rhythmia, from Carto to this software, and we are asking numerical simulation. So what we do is basically to pace from south. You see this is the circuit and is inducing VT, but it's a very polymorphic VT, different exit. While when you pace from the southeast, you see the pacing is crossing the scar. There is some beat, but then it's stopping. Indeed, when you pace from east, the scar induces a VT and is sustained. Indeed, when you pace from other side, the wavefront are crossing the scar, but are not inducing any kind of VT. So in conclusion, mapping is the most important step of VT ablation procedure. The multi-electrode multi-spline tools are the keys for the better definition of the electrical substrates. And substrate-based approach only is feasible by identification of the diastolic pathway should be always aimed. And the future is fast approaching with conduction velocity definition and with the prediction of the potential VT circuit. Just say thank you to all the team, especially to Greek guys that are working with me, Dr. Alexios Agis and Dr. Yorgos Titsinakis. Thank you.
Thank you, Antonio, for excellent talk. Have a seat, please. Thank you. Any questions? Okay, I think the substrate is the most important thing before to ablate, no? And the new technology gives to us the ideas where we have to go. And with this way, we have a successful ablation, okay? Okay, so it is for, we have a patient who with ischemic heart disease, heart failure, and VT. The first approach is to go to ablate the substrate, the VT ablation, or to implant an ICD.
Very good question, thank you. Well, I do believe there are some studies that showing that also first approach ablation in patients with severe heart disease could be an option, but usually you should implant an ICD, you should treat the patient with drugs, and then if it's a recurrent VT, well, you have to take him to the lab to study the substrate, especially if these VT are slow and well tolerated.
Okay, so for the patient, the safe is to go to implant an ICD, and then we have storm or slow VT, we have to ablate.
Well, and if there is an arrhythmic storm, for sure, or incessant VT, absolutely you should take him to the lab. And there is also a recent paper on Europace that say that if you take him within the 24 hours, so in one day from the admission, the mortality intra-hospital is very low. While if you procrastinate and if you take the patient to the lab after the 24, 48 hours, the mortality is very high. So if the VT is incessant or VT storm, immediately to the lab.
You have to go immediately to VT ablation.
Yeah,
okay, okay. What is your idea? We have to go to ablate in the same time in an epicardia in the same time, or we have to have a step to ablate at the beginning endocardial, and if it is unsuccessful to go to epicardial?
Well, if it's the first approach should be endo. If the electrophysiologist is confident with the epicardial puncture, and if he doesn't find any VT secret, endo should go also epi. Depends also on the scar where it is, but usually most of the VT, especially in the ischemic patient, are endocardial.
Yes. So, okay, less epicardial for ischemic.
Yes, yeah, absolutely.
What is your opinion about dilated cardiomyopathy? We have some difference to approach VT. We have different to substrate. What do you think?
Well, ischemic are very easy, let's say, because the substrate is always endocardial, while epicardial, well, for non-ischemic dilated cardiomyopathy, more often is mesocardial, so it's AP or intramyocardial, so it's often is really a problem to ablate this patient, and also the recurrence of VT is quite high compared to the ischemic patient. So for ischemic, I'm sure the recurrence is, the literature demonstrates the recurrence is very low, but as soon as you move to dilated non-ischemic cardiomyopathy, substrate is really difficult to map. So this is a real problem.
So we have some difficulties for non-ischemic cardiomyopathy.
Yes, there are a lot of difficulties, and imaging, I do believe, will help in the future to characterize where the scar is, and can guide, and maybe also the ablation, the new ablation technique, especially the needle, there is a new ablation catheter with a needle that is able to penetrate in the scar, because in dilated non-ischemic patient, the scar is inside the myocardium. This
Okay,
is the
so
issue.
we have new instruments to
Yeah.
go in the
Yeah.
myocardium. Okay. What do you think about VT and RVD?
VT-RVD has a very good outcome. The substrate is epicardium, and is often easy to map. The VT are not very fast, so I would not say easy, but it's not like in dilated non-ischemic cardiomyopathy. So the recurrence rate is really low of VT. So.
Okay. Okay. And what do you think about Brugada VT and ablation?
Brugada VT and ablation is a really hot topic now. I do believe in patients with several storms with VF, with the VT, VF mainly, and several ICD shocks, the ablation could be contemplated. Okay. The ablation could be contemplated because there is some, you can do something, you can modify the substrate. Prevention of arrhythmias in patients that are okay, that have no symptoms, no shocks of the ACD, well, in that case, I don't think ablation will solve the problem.
Okay. And what do you think about HOCM VT?
Hypertrophic cardiomyopathy is like non-dilated ischemic cardiomyopathy. It's a very deep substrate, so it's really difficult to ablate. So because you cannot penetrate in the substrate, you can modify the substrate, but you can't tell, I'm sure I eliminated everything.
Okay. So we have a patient 20 years old, HOCM, ICD, and a lot of shocks. We can do something for this young patient?
Absolutely.
To go to ablate?
Absolutely.
Okay.
Because if you are lucky, or you can easily identify the substrate, and you can make a good prognosis for the patient. At least is an attempt. Okay. But you can't leave the patient with 20
Okay,
shocks.
it is very difficult, but it's the last attempt for this patient.
Yeah.
Okay. What's your opinion about medicine's NVT?
About?
Pharmacology's approach to NVT?
Well, I think it should be always contemplated in our laboratory. Before the patient comes to the lab, we use all the spectrum of drugs, so from mexiletine to the usual amiodarone, procainamide. So we use all the drugs, and I think every electrophysiologist and cardiologist should know how to use them and when to stop them also before the ablation.
Okay, so the first step is to use the medicine before to ablate?
Well, if the patient can't tolerate DVT and these are no giving, so many shocks for the patient, so the first attempt should be always drug. Okay. And then if the recurrent VT recurrence are so high, well, you have to take the patient to the lab. Okay, so what do you prefer, to go to give B blockers and amiodarone? What is your step? Well, for sure, depends also on the ischemic, on the cardiomyopathy behind. So for OCAM patient, for sure, amiodarone is the first step, together with beta blockers. Ischemic are answering very well to beta blockers. Also lidocaine for ischemic patients. So these are, I think, my three favorite drugs. So first, beta blockers in every patient, then amiodarone, and lidocaine for acute incessant VT. Okay. And then mexiletine. If lidocaine fails, mexiletine is a really excellent drug. Okay, okay. So, Thanasi, να πεις κάτι?
At the moment, congratulations, very excellent talk. And I think that all the questions about the issue have been contemplated.
Thank you for the invitation. Thank you.
Γιώργος Κουριανίδης, do you have any questions?
Thank you, Your Excellent talk. I'm just wondering, you show us in a very excellent manner the way the substrate behaves during various pacing sites. Do you think that in the future we can see more on autonomic neural influences on substrate behavior, autonomic nervous system?
Yeah, thanks for your question. Yeah, I think there is certain degree of contribution by the sympathetic tone to the VT circuit, but I don't think it has some influence on the beginning. So the beginning is always pure electrophysiology. And then maybe I agree with you that the sustain of the VT, so if the VT sustain and also the triggering of extra beat is based on the autonomic tone. So that's why we have to use beta blockers.
And about the stellar ganglion?
Yeah, at my hospital, at our hospital, at my institution, we do stellar, this operation in certain case where drugs fail, where VT ablation fail, and we did the last case in a 55-year-old man with dilated non-ischemic cardiomyopathy, and after three attempt of VT, the patient had always VT shock. So in that case, we performed the ganglion stellum operation.
Okay, any questions, please? Okay, thank you, Antonio, for
My
your
pleasure.
talk. It was very nice to meet you. Thank you very much.